Well, I'm Dick Kronmal, professor of biostatistics. I joined the department in 1964, right out of graduate school at UCLA, where I had just finished my PhD in biostatistics. When I joined, we were a department of preventive medicine in the medical school. And the chair of the department was Tom Grayston. The head of biostatistics, I'm not sure whether we were a division or whether we had no formal title, was Ed Perrin. And then the only other member of the department at the time was a fellow by the name of Blair Bennett, who basically was the person who did most of the teaching in the biostatistics to medical people in general. And Ed had come probably just very shortly before I got there, I think, when he had actually joined the department. And basically I came to the UW primarily because I wanted to be in medical school, actually. The department here was in the medical school. Actually, I wasn't anxious to go into a school of public health, to be truthful. Having come from one at UCLA, I really wanted to be more involved in medical research and less in public health research, which to me at the time meant largely things like health services and health education, which I had very little interest in. And then one of the funny kind of coincidences in all that is that when I was applying here to the UW, I also applied at the University of Pittsburgh, where Donovan Thompson was the chair of biostatistics in School of Public Health. And when I interviewed with him, he asked me where else I had offers from, and I told him UW and a bunch of other places. And he told me he didn't think I should go to Pittsburgh. He said he thought I should go to the University of Washington. And of course, maybe it was several years later, he of course joined the department as a faculty member, and then eventually became chair of the department for a long period of time. And I guess another interesting factoid is that I was responsible for getting Pat Wall largely into biostatistics in the School of Public Health. She was, when I met her, she was working as a programmer in the computing facility of the university. And so I consulted with her about programming issues I had, programming problems, and found out that she had been a math major. And at that time I was very much a recruiter for the biostat program. Anytime I had an opportunity, I tried to recruit promising young mathematicians to join the department. So I actually recruited Pat, and then she ultimately was my PhD student as well, and got her degree with me. And later she joined us on writing a couple of big research grants, and so she and I go back a long time and are good friends. Other comments, I guess, maybe about Donovan a little bit. Probably more than anyone else, he was sort of a father figure to me. There probably wasn't a day that didn't go by that I didn't stop by Donovan's office and talk to him about just about anything, whether it was statistics or, my personal life or just about any topic at all. He was, both a mentor and a father figure in large part. He was also an incredibly effective department chairman in that he had a way of getting decisions made without anybody knowing that a decision had been made. And so he would always get a consensus, even though people never realized that he was. which made him an extremely effective leader. And of course, the other thing about Donovan, which of course you probably heard, is he was a very avid golfer. He was a member of the Sandpoint Country Club just up the street, and the one thing he always said was that when he died, he wanted to die on the golf course. And in fact, that's what happened. He had a sudden cardiac death or an MI, I don't know which, while he was playing golf, and died right on the golf course. And he always, many times he would say that one thing he didn't want to do was linger, to have a slow death. He wanted to go quickly, and he got his wish. And we were all obviously sorry to have him die at that time, but it was, on the other hand, in some ways, I thought to myself, here's a man who lived the way he wanted to and died the way he wanted to. Kind of a fortunate thing in its way. He was a very fine person, and of course, when he did die, we all missed him greatly. Other reflections? One thing is when, there's a story that a lot of people in the department know, but when preventive medicine was discussing becoming a school of public health, we actually had a vote as to whether we were going to become a school or not. And the primary, at least one of the major reasons for becoming a school was that there was federal money available that only went to schools of public health. And it was a substantial amount of money. And it didn't go to preventive medicine departments. And so the preventive medicine department here couldn't really do a lot of things it wanted to do. And so it was decided by Tom and others in the department, I guess, to attempt to become a school of public health. And we had a vote as a faculty for that. And I probably, although I don't know because it was a closed ballot, I probably was the only one in this school, in the department, who voted against it. And again, my primary reason was the same as the reason I came to the UW, is that I really wanted to be in the medical school and didn't see the advantage to being in the School of Public Health at the time. There turned out to be a number of advantages. I mean, we have now a major department of biostatistics, probably the best in the country, and that wouldn't have been possible in the School of Public Health. So that I was short-sighted probably in my opposition. The other major role I played here was I was involved heavily with at the time people mostly in the staff department and Ed Perrin here, and a few people in fisheries and forestry that were quantitative ecologists in the formation of what ultimately evolved into the Department of Biostatistics, but started out as the biomathematics group. And I was the first chair of the biomathematics group and served in that capacity for, I believe, 14 years. And we started off as a program that was very broad-based, that included everything from classical biostatistics to quantitative ecology, statistical genetics, and pure biomathematics. And so we were very broad-based, recruited students from all over the country in a very broad-based manner. I think we started out with a class of 3, and in 4 or 5 years we were having classes of 40 and 50. So we had a very rapid growth in the program while I was chairing it. And our graduate degree was through the graduate school. It was not through any given school. It resided in the graduate school because it was multidisciplinary. And then eventually, it was decided that the department wanted its own degree separately, and the quantitative ecology wanted to do its own thing. So ultimately, soon after I was stepped down as chair of the group, the graduate degree there was a separate graduate degree awarded to biostatistics and quantitative ecology. I don't know whether they have a separate degree or whether it's through fisheries and forestry, but it had its separate degree as well. And so that changed the focus from this very broad-based program to a somewhat more focused more traditional biostatistics program. As far as the field of biostatistics goes, since I came and started in the field, obviously there's been massive changes. Much as I discussed when I gave my talk to the school, as distinguished faculty lecture, the biggest change is really the computer revolution, really. It had profound effects on biostatistics. When I came, we were still using punch cards extensively, sorting machines, key punch machines, and a big central computing facility. And I can still remember having to turn boxes of cards into the computing facility and have to come in the middle of the night when the program went run to see what went wrong and watch the be there so I could hit the button to dump core on the computer so that I could see what the problem was. And then it was what I had was only pages and pages of numbers that I had to translate where the program was and where the data was and find out what was wrong with the code I had. So you contrast that to now, when the machine that the whole university had was nowhere as remotely as powerful as what I have on my desktop. It wasn't even close. So it was really incredible to see this evolution take place over so many, over such a relatively small length of time, and it's something that those of us who watched it could never have predicted. If somebody would have told me what things were like today 40 years ago, I wouldn't have believed it. I would have said they were full of it. So that's been the biggest change, because biostatistics is heavily dependent on the computer. In fact, our whole research enterprise is heavily dependent on the computer. The school, when I for a while basically introduced computing into the school, actually into the biostat department, into the school. Our department was, for example, probably one of the first on campus, if not the first, to have a word processing system. We actually got a word processing system that was built by a subsidiary of one of the major oil companies, which eventually they went out of business, but because they didn't keep up with the changes, and because, of course, personal computers came in, and you didn't need centralized word processing. But we had our own centralized word processing system for the whole department many years before anyone else was doing that. We also, I'm sure, had the first mini computer in the School of Public Health, and which was basically something that I ran the school's computer facility and got the first mini computer. I think we had the 5th IBM mini computer ever built. IBM had actually flown me out to their plant in Poughkeepsie to see the computer, and it was because it was such a new thing to have a big, what then was considered a big mini computer, namely a small computer, but compared to the big mainframes, it was quite small. And at that point in time, I helped develop one of the first database programs for any sort, really, and it was dedicated to doing our big longitudinal studies, to make sure we could process the data, which was a big problem because we just didn't have the computing facility or the software to do it. So I did a lot of work in database management, and we had a very good database management system that was quite unique for its time, and really preceded the standard database management systems that are in wide use today. I don't think it influenced them at all, but because I wasn't Microsoft, but nonetheless, it was for its time very innovative. The fact is, part of it was one of the first spreadsheet programs, if not the first spreadsheet program. Even before VisiCalc, we had a spreadsheet program that we had developed, but unfortunately I didn't realize that it might have wide-ranging applications and could have made me a multi-billionaire. Had I done so, I might not be here today talking to you. I don't know. Beyond that, in order to do a lot of the statistical procedures we use today, would virtually be impossible without computers and the modern computers we have. Even when we are starting to run big medical research projects where we are coordinating centers to run, for example, this big coronary artery surgery study that we had, and had a big mini computer. Even then, it would sometimes take overnight to just run one statistical analysis. Now that same analysis would take 30 seconds, maybe less. So, what used to be 8 hours is now 10, 15, 30 seconds, something of that order. So it's a amazing revolution that's taken place, and it's changed the way statistics is done in remarkable ways. In fact, just now, none of us use central facilities at all. We do all our work on our own computers, desktop computers, and so it's even though we have massive databases and incredible computational needs, but the computers we have are completely up to the task. So I'm going to give you an example. The first computer we had 8,000 bytes of memory, and the disk was 150,000 bytes. And that was a disk which you had to take in and out, to put the next 150,000 bytes in. So it's an incredible difference from what we have today. And again, as I said, that's changed the way we do things. I mean, it makes possible so much more than we could have ever done before. And that makes it's like what's happened in general in society is our productivity has gone up incredibly dramatically. I mean, things that would have taken us months to do are done in a day now, and or in hours even at times. Because instead of having to wait days for results, you can just get it instantaneously. You can go on to the next thing, and so on. So that's been the giant revolution in the field. In my career, the people who had big influences besides, would be, I would have to say, Tom Grayston, and obviously Donovan Thompson. And the other person who's had a big influence on my career is John Fox. John was very much an old-time epidemiologist who was trained and worked in infectious disease epidemiology, which was the focus of our department and the school when it first started, because that was Tom Grayston's background as well. And I worked with both Tom on his study of pneumonia, and then John Fox with his study of viruses in the families for when I first came here to the UW. And then John got me involved with a man named Leonardo Mata, who was a researcher in Guatemala at the time, and who was studying health, growth, and nutrition of Mayan children in a village in Guatemala. And at that time, at least, it was the most data-intensive study that I'd ever seen. There were 48 children enrolled, but he had literally several thousand cards worth of data on these 48 children because he just intensively monitored them from birth till about 6 years of age. He was later nominated for a Nobel Prize, which he didn't win, but he at least got a nomination, which was quite important. So that led to a lot of interesting collaboration over a decade or so with Leonardo in Guatemala and multiple trips there. And he came here for a year and spent a year on sabbatical here, where he wrote a book on the study. And that was a very interesting experience, and we learned a great deal, mainly the incredibly important role that disease plays in growth. That, the overwhelming factor for the stunting of growth in these Guatemalan children was not their nutrition at all. We found out the nutrition, which on the surface looked pretty poor, was really not that bad. But they would average 8 infectious diseases every year from the time they were born, and some of them were, serious diarrheas, serious upper respiratory illnesses. And during the periods that they were sick, they didn't grow. And they had no palatable source of calories. They got most of their calories from tortillas, which you can't eat if you're sick very easily. And so the net result was they failed to thrive and would become very stunted in their growth. And most of the villagers didn't even get to be 5 feet tall. So anyway, that was an important learning experience and important scientific findings from his study. I suppose thinking of my own career sense, one of the studies that I'm most proud of that I was involved in was a study that focused on prevention of stroke. And I got involved with some researchers at the University of Texas at San Antonio, a fellow named Bob Hart and Dave Sherman. And they wanted to do a clinical trial in people who had atrial fibrillation, which is a common cardiac arrhythmia that increases the risk of stroke dramatically. And at the time, it was not clear what appropriate treatment was, and so we did a large clinical trial testing aspirin versus blood thinner called warfarin versus placebo that lasted for 3 or 4 years. And the results were that there was a dramatic decrease in risk in those who were taking both aspirin and warfarin. And the fact is that this treatment, which is now the standard of treatment in the U.S. and worldwide really, has probably saved tens of thousands of lives and people from having strokes over the time since that study completed. It had a massive impact on medical care, and so I look at that as a major achievement, and which was a very rewarding activity. Otherwise, I've been working primarily in this organization, the Collaborative Health Studies Coordinating Center, which I started, and started out as a joint project with Lloyd Fisher and from the Department of Biostatistics and Catherine Davis, both of whom are now retired. And it was a study of comparing bypass surgery to medical therapy, and it was a landmark study in its own way because it was very rare for studies to compare a medical therapy to a surgical therapy, and we were able to show after a long study that, but we were the coordinating center, so we did the statistical analysis and data management and the like. We had multiple clinics that were involved in the study. In any event, we were able to show that there wasn't any real difference between bypass surgery and medical therapy in terms of survival, which was our primary endpoint of our study. And again, that probably had a major effect on medical practice in the United States, where up until that time, everybody got bypass surgery if they had the right set of symptoms. And how much it changed is hard to know, but we at least feel that probably had a big impact. And from that coordinating center, we bid on a contract from National Heart, Lung, and Blood Institute to do a large study of cardiovascular disease in the elderly, called the Cardiovascular Health Studies, and became the coordinating center for that. And it was a study of people from 65 to 99 that were in 4 field centers around the United States, and we're followed now. We're still following them. It's our 19th year, and more than 50% of them have now have died since the beginning of the study. but we've learned a great deal about cardiovascular disease in the elderly and the factors that lead to it and the consequences of cardiovascular disease. And actually, it really influenced, medicine in a variety of ways. One of our major findings was that there were two forms of heart failure, where it was thought before there was just one form. And one of our studies basically showed that there was actually a second form that was actually quite common and had a quite different, underlying etiology. Also made major findings in kidney disease. So the studies had some, and we understand much better cardiovascular disease and its progress in old people than we did before the study. Right now, we're also running another large coordinating center called the Multi-Ethnic Study of Atherosclerosis. And that study started about 7 years ago and is following a large cohort that's made up of Chinese Americans, African Americans, Mexican Americans, and Caucasians. And 6,800 people from 45 to 85 years of age. And again, it has similar goals, and we're measuring a lot of factors on these people, and they're healthy, basically, when they start the study. And we're trying to understand what leads to subclinical cardiovascular disease and what the impact of subclinical disease is leading to clinically recognized disease. And so the study has measured lots of high-tech things on people using the latest technology. And so it's still ongoing and will run hopefully for another decade, we hope, before we'll have complete answers on all the questions that are being posed by the study. We also run a study here of it's a randomized clinical trial in people over 75 to see if ginkgo biloba, the herb, will prevent dementia. And that trial is randomized 3,500 people to ginkgo or placebo, and has been going for about 4 years now. Has about another year to run before it's finished. And then we'll know what the results are about a year from now. Otherwise, we have a lot of other smaller projects that we work on with investigators around the country. Some of them are attached to our big studies, our MESA and our CHS studies, so that people will write proposals to do ancillary studies to these big proposals. And some of the ancillary studies that are going on are almost as big as the parent study. And for example, the School of Public Health and Environmental Health has a huge EPA grant to study air pollution and its effect on subclinical cardiovascular disease. And the MESA cohort is being used for that purpose. And so they're getting air pollution data on the people in our cohort and are going to follow them forward in time and see how much their underlying subclinical disease progresses. And we have a large family study for looking at genetic factors leading to cardiovascular disease. That's also part of the MESA study. And there's another genetic study part of the CHS study as well. And all these studies, we have really good collaboration with researchers in the epi department here, and in environmental health, and in medicine as well.
Dick, you've been in an unusual position in terms of Pat Wall, recruiting her as you did, and then serving as her PhD advisor, and being around to see her go through rise in the faculty and then be named dean. If you have some stories, fine, but observations or insights, please tell us more about that.
No, I don't actually have any stories. I mean, of course, Pat has always been an incredibly good, calm administrator. And but I would have, if you'd have asked me, I would have never predicted her to be dean of the school. It was, it's kind of funny how things evolve, in ways that I think it's a lot of chance involved in it. But certainly my observation of her is she's been an outstanding dean. And during when I worked with her, she was also always clearly, she had good administrative skills, excellent administrative skills. That was always apparent. But I'm not sure exactly how she ended up gravitating there. I mean, I know she was offered the position with Dean Oman, but I don't know how that happened, what led her that direction. So I don't have any particular reminiscence of that.
Well, Dick, you've had the opportunity, other than observing Pat, to see all our other deans in action. Dr. Grayston for a year, and then Bob Day and Gil Oman. What are your general observations about those leaders of the school?
I knew Bob Day from UCLA when he was there, because I was a graduate student when he was on the faculty at UCLA. And in fact, I worked with Bob on my biology project as part of my PhD. I did a genetic project with him because I had sort of minored in human genetics. And when I was with him, he strongly urged me to go to medical school, to get my PhD and then go on to medical school. And but I just couldn't see it. And I had a child on the way, and there were lots of reasons why going to medical school didn't seem to be in the cards at that instant of time. But so it was a funny coincidence that he ended up here as well, and ended up being the dean of the school right after Tom Grayston. Actually, while he was dean of the school, I didn't have a lot of interaction with Bob, and we had some, but it was mostly peripheral to things. I had more interaction with Gil Oman, however, because Gil had interests in that overlapped with our research interests, and so we did some joint papers together, and so I had a fair amount of dealings with him over the years he was dean. And of course, as I'm sure other people have told you, he was one of the most driven people that I've ever met. I mean, I can still remember finding notes slipped under my door in the department that had materialized in the middle of the night, I think, that he had had something he wanted done or some idea, and he'd slip it under the door because he couldn't get in. So yeah, Gil was, and of course, an extraordinary hard worker and incredibly dedicated. So no, I always got along really well with Gil and enjoyed working with him. And Pat has been a great dean, as I said, and obviously has been very very oriented towards all the departments really, and trying to foster them and make them succeed. And that's been one of her great strengths, actually.
Dick, you mentioned your work in Guatemala. I'm wondering if other work that you did would come under the rubric of global health or international health.
Other than the work in Guatemala, I didn't have a lot of contact with global health. The coronary surgery study that I mentioned earlier, we had an exchange program of sorts with the Soviet Union, where they had investigators would come out and visit us, and then we would go to the Soviet Union and visit them. But it was actually more of a political exchange than a scientific one, in that it was more to foster the idea that scientists could work together across the red curtain, than it was that we actually did anything productive. I mean, we all got a great tour of the Soviet Union, and they got a great tour of the U.S. when they were here. But it wasn't very much a scientific exchange, although I think it was, that was under the way that the NIH looked at it, and why they were funding it, but it really didn't do a whole lot. And I enjoyed meeting the Soviet investigators. It was quite interesting. It was quite interesting seeing their medical care system just before the collapse of the Soviet Union. It was pretty bad. So bad that you go in the hospitals and there'd be no toilet paper in the bathrooms. They had stand-up toilets. Sanitation was horrible. It was quite an eye opener. And when they would come here, it was very strange because they even though they were physicians, they just couldn't believe the way people lived here. They just didn't want to believe what they saw because they couldn't. It was so foreign to them, really. As foreign as the way they had to live was to us, it was equally foreign to them how we were able to live and the facilities we had. And I still remember that they had a guy on the trip who we were sure was a KGB agent, because that's the way it was. They were out of the country and you had a KGB agent with you. And I still remember going into the first hotel we stayed in the Soviet Union. One of the people went to their room. While they were in their room, the light fixture in the ceiling fell out and a microphone fell down. It was that bad. And we were pretty sure we were followed everywhere we went, even though we didn't know for certain, but we were pretty sure we were. So, as I say, it was an interesting, very, very interesting culturally experience for me, but not much of a scientific one. Obviously, global health today is quite different, and those kind of problems aren't the ones we're facing. One other international health experience I had was, again, probably through Russ Alexander, I think, where we they had collaborative research with the Naval Medical Research Unit in Taiwan, and so that was another area where I got another wonderful international trip, and did a few collaborative papers with investigators that were working in Taipei for the Naval Medical Research Unit. And there were other School of Public Health faculty that were involved with that unit. Jim Gale, who you probably have met or will, I'm sure, interview. And so that was another one of our ties with international health. And of course, in fact, the department had extensive ties in international health in its inception. The school did, in the Department of Preventive Medicine. It was heavily in that. Tom Grayson, as you know, was heavily involved in international work. And had ties, in Taiwan, as I said, and so that was the only other major activity we had that I know about, in international health early on.
As the department grew into a school and a smaller group of colleagues became a larger group of colleagues, what was gained? What was lost? What are your thoughts on the department becoming a school, and not just in a professional sense, but also in a personal or a social sense?
Well, I have to say, for me, it wasn't tremendously different. In the sense that, I think professionally we had much more interchange early when we were smaller. There's no doubt about that, because we'd all go to lunch together in the medical school facility. We would talk about things. Everybody was working on research together. So in that sense, there were closer contacts. outside of, I mean, I'm sure there were, I mean, obviously when we got so large, you couldn't have, social gatherings that would have everybody in the school because the school was way too big for that. And of course, we didn't know each other most of the time. I mean, I didn't know a lot of the faculty in other departments. But it wasn't a school, even when we were a department, it wasn't a department that had I would say, a heavy social life, at least not that I was involved in. Partly, maybe that was me. I don't know, maybe other people did.
You didn't get invited, huh?
That may be. But that's possible. But we got big fairly quickly. Once we became a school, it didn't take very long. The school was very successful. I mean, it was obvious from the stature it has today and the size it has today. So it grew very rapidly, and of course, with that growth became much less exchange. I mean, that doesn't mean there isn't some now. There is. I mean, I work a lot with some of the epi faculty. And a number of my friends, faculty from epidemiology, and I know there's faculty that work with health services, in particular Paula Deere, for example. But other than that, I don't think that there hasn't been. There is a more of a barrier between just because of size and because everybody is busy. I mean, the really underlying thing that's changed is the modern world. I mean, in point of fact, it's nothing to do with any of the people so much as that everybody is incredibly busy. And so, you're so busy, you don't have time for anything else. You don't have time to, socialize in the halls, and we're bombarded with information, and we spit it out and take it in at incredible pace today compared to the way it used to be. And that's just a function of the modern world we're in. And it's changed the way we do everything. It's not just our work, it's our leisure. We're walking around with phones attached to us, and, and those things have changed our way of life. And it's part of the evolution of the species, if you like, the cultural evolution.
Sad but true, I think. I mean, it certainly has made us more efficient in some ways. I mean, when you speak about what happened with the computer revolution and how you can do in minutes what would take days, if not months before, but at a cost.
Yeah, there's a cost to it, and there's good and bad things about it, like everything. But I tend to look at these things in the sense that every society evolves, and we evolve in ways that we don't have any full control over, but they nonetheless, it's what the society needs to do to exist in a way, and it's almost like, you ask the question, well, at one time we were hunter-gatherers. Would we want to go back to that? No. Then we became industrialized, and then we became computerized. And, each of those things had its good and bad things about them. And so it's hard to, you can't evaluate them, I think, when you're living them very well. Because you can't step back from them very easily. You only see the bad things you lost or the good things you gained, but you can't see them in perspective. And I don't think we're in a good position to evaluate ourselves in a lot of ways. This is off the subject, of course.
You have told us a bit about Donovan Thompson and John Fox, but these are two folks who can't speak for themselves, and if I could tease you out a little bit more, if you could think of any other observations on either of those two, we'd appreciate it.
Well, let's say for Donovan, it was much more for me that again he was kind of a father figure, as I said, and he was at the sort of tail end of his career in a way when he came here, and so his great impact here was in helping the department flourish, and he did that by basically knowing how to delegate. He knew how to give people enough freedom to work and to accomplish things. He was very good at judging people, so he was very good at making sure that the faculty we hired were of high caliber, and so that's what he was a mentor, basically. He was somebody who was always encouraging, always upbeat.
And he was quite a bit older than other people in the department, was he?
Yeah, oh yeah, he was quite senior when he came here, and for most of us, that were junior faculty, he was a father figure, I think. And I think not only for me but for others as well, and very much a mentor, very much loved by the people who worked under him. And not to in any way denigrate the other chairs we've had, who've all been wonderful. He was a very unique person in that way. Almost really an extraordinary person that way. It's hard to... You don't come across an awful lot of people like that in your life, really. John, again, my contact with John was almost entirely, as a colleague, and so I don't know a whole lot about it. He came in here late in his career, and he had one big study of virus diseases and families, which I actually I actually joined the study as both the statistician for it and a participant, because I had young children at the time, and I qualified, so I got enrolled, and we had to take a lot of throat swabs and including crying babies, and but it was interesting, and I found out all the different infections I got every year while I was in the study from my kids. But after that, John didn't do a whole lot. He was really at the very tail end of his career, and I don't think he had any major scientific things after that study was over. I don't know how long after that he retired, but it wasn't a long time after that. So again, I didn't, most of his career was before he came to the UW. Other than that, recollections. There was I knew a fellow named Ed Boatman, who people may have not mentioned to you, who was in the department. He was an electron microscoper, and he ran a big microscope, and my contact with him was kind of funny because I was interested in the inheritance of fingerprint patterns. I had worked on that as a grad student at UCLA. It's part of my biology project at UCLA. And so we wanted to do a study of the inheritance, and we wanted to collect new data on fingerprint patterns, because there's fingerprint patterns are related to congenital heart disease, turns out, surprisingly enough, because they develop at the same time the heart does, the pattern, I guess. Anyway, so we decided we had to figure out a better way of getting fingerprints than using what's done in legal situation with a ink pad and all the other things. We needed to have a way of getting a photograph that was better. And so I happened to be sharing an office with Ed Boatman in the medical school, because the office space they were building the school of public health at the time, and office space was very scarce. So I had an office with 3 other people, and I was sharing with a print dryer, drying the dried photographic prints from his microscope. And it would be very hot in there sometimes, and so in the middle of winter we'd have an air conditioner going, the print dryer going, was blowing out heat and noise, and the air conditioner all going at the same time. So I got to know Ed, and he so we actually invented a new way of getting fingerprints done using a prism, and so you could put the finger on the prism and shine a light through it, and then photograph what came out, and you could actually get nice images of the photograph. And he developed this, so we were working on automating all that, and never actually ended up completing the project. But he was an interesting guy, very short. He must have been 5 feet tall at most, very slight. He was a rowing, and very nice man. He was one of the, again, old timers in the department that I got to know fairly well over time.
Well, you got my curiosity going on this one. A relationship between heart disease and fingerprints. Could you just flesh that out?
Well, to be honest, I don't remember a whole lot about it. It was certain patterns of fingerprints, whether you have arches or whorls or some other configuration, turns out to be associated with congenital heart disease. And it's inherited. The fingerprints are inherited. The patterns are inherited, and in a very complex way that I don't think. I tried to work out the inheritance pattern, and I thought I had figured it out, but I never was sure. And so we were trying to work out a project to look at it more carefully in congenital heart disease, and I say never got far enough on it. We really wanted to have a better way of doing fingerprints that didn't smack of criminal, activity, because we thought people would be leery of letting themselves being fingerprinted if they were done, the old-fashioned way with black ink and pads. It was messy. But we never were able to really pull that off.
Please tell us a bit more about the Collaborative Health Studies Coordinating Center that you direct.
Well, as I said earlier, we started out as an outgrowth of first from the coronary bypass surgery randomized clinical trial, where we were a coordinating center, and then we competed for the cardiovascular health study, which I also mentioned earlier, of the elderly. And when we won that project, we had maybe we were maybe 15 people then. This all started back in the 70s, and then we thought that the cardiovascular health study might end. It was up for renewal, and we didn't know it would be renewed or not. So we then bid on this multi-ethnic study of atherosclerosis and got it. And then all of a sudden, we also saw an opportunity to do this study of ginkgo biloba, and we bid on that. And all this sort of mushroomed until from, starting out very small with maybe 8 or 9 people originally, now we have a staff of probably 40 FTEs here, and have this, floor in the Sandpoint, what was the medical clinic of the Sandpoint Naval Air Station at Magnuson Park, and are still competing for other other grants and contracts over time.
Well, I want to thank you for a fine interview, and also say what an amazing view it is out your window.